Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's such a special honor and pleasure. We have a world famous speaker and friend of mine, and I am a little bit scared because tonight we have as a guest my boss. He is the president of the European Academy of Osseointegration, Ronald Jung, Professor Ronald Jung. Ronnie, thank you for making this possible for us. It's a great pleasure. Welcome to the EAO show.
Thank you so much, Stefan, for this world-class introduction. Like this, we can do this every Monday. And I have to say now, on behalf of being the EAO president, on behalf of the board, we are very proud having such an prominent and kind of experienced moderator for this Just Ask session. I think you really added to this session something very special. And I'm very proud and was very much looking forward to our evening tonight.
Ronnie, thank you. Don't turn the table around. You are the star of the tonight session. Just very briefly, I think everyone knows you. You're the president of the European Association of Osseointegration. You hosted so many congresses. You were speaking on principally all of the big congresses. You published so many landmark papers. I adore you for so many papers, starting with the punch graft and everything. And you are the chair of the world famous reconstructive dentistry session in Switzerland, Zurich. So for me, it's a great pleasure to have you. Again, hello, Ronnie, and thanks for being there.
Thank you so much, Stefan, for this super kind introduction. Most important, whenever I want to introduce myself, is I'm one of the most passionate dentists which you can have. And this is what I want to also share with you, Stefan, but also with the EAO community, because I think we can be so proud being dentists. I think it's such a great job. And today I think we want to share a little bit this fire which we have for our profession with all the EAO community and the friends out there.
Absolutely true. And Ronnie, everyone who sees you and who knows you, he sees that in your eyes, the glowing of your eyes, and you just love this job. Ronnie, we have a lot of people already logging in from all around the world, probably all the countries you were traveling to, with people from Saudi Arabia, from Norway, from Sweden. We have also other Germans logging in. We have other Swiss logging in, and everyone is really looking forward to your presentation. Today, you were on my wish list, and I was very happy that you agreed. And the topic was one of my wish lists because short implants. And Ronnie, I knew I'm going to have you as a speaker tonight. And last week, a patient came by my office where I placed some short implants some years ago. And I thought, come on, I'm going to share this with Ronnie. And Ronnie, just sink in your thumb. Put up your thumb. Was it good? Is it not good? What do you think? Was it the right approach? We had Massimo Simio here. He would have probably said, Stefan, this is a case for a vertical augmentation. Was I wrong? Was I right, Ronnie? What do you say?
No, I think when I look at this situation, and I think we will see also during this hour 45 minutes we have together, I also underwent kind of a journey. And today, for me, most important is to provide the patient with the least invasive, maximum effective therapy. And when I look at here, you managed in a very minimal amount of bone, you managed to place 3 short implants, and you provided the patient with additional 3 units and a life comfort without going too far in terms of invasiveness. And from that point of view, I think this is exactly what we should today in modern implantology. It's not about showing off how amazing and how big I can make augmentation. It's about, again, finding the least invasive way with the maximum effect. And I think here you have chosen, for me, a great way. You had the 3 crowns. They look at the moment like the proportions between the crown lengths and the length of the implant, that they don't look the way we might think. But we also will address this crown to implant ratio within the presentation, and we'll discuss whether this has an effect on the long-term outcome of implants or not. And I think this is what makes the topic so interesting. And I have to say, it is a topic. And again, I'm very happy to share with you my journey, because I did came from another angle, and today I have a very clear understanding of when using short implants and when not using short implants.
Perfect, Ronnie. Thank you. And I'm a little bit relieved that you think it is a good way to do it. And maybe next time we have Massimo coming in and we're going to battle about the right concept.
Exactly.
But now, Ronnie, we want to hear your presentation. And we agreed on, you know, it's a little bit of tradition of this Just Ask, that we keep it very interactive. So it's not unpolite if I just stop in and ask you a question, and I'm more than happy to your presentation. And please, the topic is, do you still place short implants? And if I'm allowed, I would like to interrupt you at any time. Thank you.
Please do so. You just started by saying I'm your boss in my current position as a EAO president, and I can tell you, you're not fired. You can stay, and we're very happy to have you, because I think you provided a great job there. Now, as you know me, I would like to share with you kind of, because I always say I don't treat teeth. I also don't treat missing teeth. I treat human beings. And I would like to start with a patient of mine, which is a patient which maybe some of you might even know. She's in implant industry since many years, and she had different executive positions, and she's 45 years old, an attractive woman, and she came to me as a patient. I know her also from different ways professionally, but she came then once to me as a patient, and she told me, listen, Ronnie, I have to say I'm very embarrassed. I'm actually ashamed, because I have no teeth in the posterior mandible. Nobody has ever seen this. I have never shared this with anybody else in my business, and I really wish to have my teeth back. And again, I could not share this, because being in that business, having no teeth, that's absolutely embarrassing. Now, Jennifer came with this panoramic X-ray, where she has her residual teeth. And we can see very typically in the posterior mandible, teeth have been extracted, obviously years, decades ago, with no reconstruction. She never was wearing a removable denture, because she wasn't feel comfortable about that. And she also felt she's a mother of 2 kids, she has a husband, she don't want to have a prosthesis there. And again, this shows me how important our job is. We do not just restore teeth. We can give this patient back a quality of life. And this is what we should do here. So we have here a situation maybe similar to the case you have treated a couple of years ago, Stefan, where we have on both sides residual bone height of about 7 millimeters above the alveolar nerve. Clinically, it looks like this, a typical situation. The residual teeth here in the front, they're basically without any lesion. So she really keeps care of her teeth. She has a past where she didn't grew up in an environment where they took a lot of care regarding her teeth. And then she has lost her teeth in the posterior mandible.
Ronnie, can I ask you a quick question?
Yes, please.
How important is the quality and the quantity of the soft tissue for you? Because a lot of people will say, okay, you place short implants, but if you place short implants, you have to have perfect soft tissues. So how important is this in your decision-making process?
This is, for me, always an important issue to address, the quality of the soft tissue. And this is, for me, independent of whether I have a short or long implant. Because at the end of the day, what we want to have is a healthy condition. Today, we had that debate regarding with or without keratinized tissue, how much keratinized tissue. But I think today we have a global consensus. Yes, having a keratinized tissue around your implant, independent of whether it's long or short or narrow or wide, this contributes to the long-term success, also primarily from a peri-implant health point of view. So that means, yes, we will address this topic as well when we talk about at the end how we have treated her. And there, before doing the implants, I can just take this, you're too fast. We did on bilateral side, we did a free gingival graft in order to increase the width of the keratinized tissue. Mm-hmm. Now, again, in such situation, as you said, we could also have a debate tonight about doing a vertical bone augmentation here in the posterior mandible, or to choose the approach like Stefan Fickl approach, as we have seen before, we're going to go for short implants. Now, put yourself in the perspective of a patient. And I always say as dentists, we should always think as a patient thinks, and we should treat the patient the way we want to be treated. Now, for Jennifer, she knew a lot of people, and she was friend with multiple well-known dentists, and she really said, I had already discussions. She was visiting different clinics, and she has not made a decision. She was in Budapest meeting Istvan Urban about addressing what should be done. So it's a true story. She was then in Zurich, where she contacted me regarding this. And she went in Rubano with Luca de Stavolo in order to discuss with him the options there. So she was confronted with the fact, which one should I use? In Budapest, Istvan suggested her for a vertical augmentation using the sausage technique. In Zurich, we were in favor of a short implant, and Luca was actually addressing these with his shell technique, like he has learned from Kuri. And again, she would have a VIP treatment in all of these cases. Now she said, listen, before I can make a decision, I'm not so familiar with the literature regarding short implants and what we do know today in 2024. I'm more familiar with what we have learned from the bone augmentation part, but I would like to a little bit better understand what do we know today about short implants. And then I told her, listen, we need to differentiate when we go scientifically into two different scenarios. One scenario is that we place short implants in areas where we don't need short implants, where we could also place a longer implant. Because there was once a theory coming also from Zurich with Christoph Hemmele, which we thought, what is the benefit of having a longer implant when we do know, also from Frank Renoir, that the majority of the load is taking place in this marginal portion? What is the additional benefit for a longer implant? How does the longer implant contributes to the overall success or health of this implant? And the second scenario is obviously in cases where we do not have more bone, where we need to take a decision either to go for a vertical ridge augmentation or to go for a short implant. So I think it is very important to differentiate between these two scenarios. And I would like to start with the first one, because that one is much more interesting. Because whenever we compare short implants in literature, usually these short implants have been placed in areas where you only can place short implants. And they have been compared with longer implants. And this is maximum unfair because you do not compare different implant length. You compare different type of anatomical situations. That means you compare a very compromised situation where you place a short implant versus a more ideal situation where I can place a 10 millimeter implant. And that's not a fair comparison. And that's why we initiated early a study where we wanted to understand. This was a study which we first published in 2016. It was a study which we did together with Patrick Schmidlin, the head of Perio in Zurich, where we wanted to look at single tooth implants, where we compared in areas where we have more than 10 millimeters, and we compare in these sites, or we randomly placed in either a 10 millimeter implant or we place a 6 millimeter implant. And this is the only fair study which has ever been done, because you truly compare implant length as the only parameter differentiating. The study underwent the power analysis. We included 85 patients, so it was a well-powered study comparing sites with 10 millimeter versus 6 millimeter implant. And from there, we do have these funny pictures, which also for me look very strange. You always think, okay, Ronnie, that guy, he ran out of implants. That's the only implant which was left, and this is what he placed.
Or he ran out of drills.
He ran out of drills, yes, exactly. And I tell you the truth, it also, whenever in the study, the case was randomized towards a short implants, you didn't felt good because placing, you would so much love to drill the length there of the neighboring tooth and make it 10 millimeter. It would feel so good. And we were asking ourselves, are we doing it for the feeling of the surgeons, or what does the length of the implant contribute to the overall success and the health? So when we look at this first result after 3 years, super curious, and we ended up with 43 implants in the test side and 42 implants in the control side. And we have lost at the very early stage an early failure of one of the short implants, which we didn't reach sufficient primary stability. Ending up then with a survival rate of 98 versus 100% with no statistically significant difference. So after 3 years, we were pretty confident, say, hey, that looks actually good. We also looked at the marginal bone level, and we could see very stable results from all aspects. And there was no difference in any aspect regarding the short and the long implants, and a minimal amount of marginal bone level changes. It's 0.2 versus 0.3. So we also looked at the issue which we discussed before. Does the crown to implant ratio has any effect on the implant survival or success? And we have to say today, we do have a good evidence, not just from this study, that the implant to crown ratio has no association with the marginal bone loss or the survival rate of implants. So therefore, your crowns there, Stefan, are perfectly done, and they're meeting the standards of today, standard of care in 2024. So there is no doubt you did the right choice there.
And Ronnie, one more thing to specify it. First of all, I'm happy that I'm not going to get fired for this prosthetic rehabilitation. But secondly, this accounts for splintered crown, but also for single crowns,
Yes.
which might be even more critical in that perspective, right?
Exactly. Even there is one very interesting study from Urs Belzer, which I admire a lot. It's an old study, which he even could show better marginal bone level in cases with a larger crown compared to the implant length, compared to more favorable crown to implant ratio. And they didn't know why, but one of the speculation within discussion was that due to the higher crown, you have less stress on the marginal bone level because the overall system is taking up more of the stress, and it's more stress on the screw and less on the marginal bone, which makes sense because when I have a long implant and a short crown, all the stress goes directly to the marginal bone. But now,
but that was probably the old metal ceramic restoration. Might not be true for monolithic ceramics, right?
Yeah, but still, I think stress is more because you still have there also for a monolithic reconstruction, you have a titanium base abutment most likely in between there, and then you transfer this on the screw. So I don't think that has that much to do with whether it's a porcelain metal.
Okay, got it.
Now I know you, Stefan, you said, listen, Ronnie, after 3 years, every shit works. So I want to know how it's after 5 years and longer. I can provide you this. This is the second study which we published, and we always publish in Journal of Dental Research, which was kind of a challenge because we know they are not so much in clinical research, so they really saw the value of such a clinical study. And the same patient population now over 5 years comparing the implants. And we have here another example at baseline, at 3 years, and at 5 years. And when you look at them, it looks really amazing. A great bone level. And you ask yourself, why the hell I should ever place longer implants? Because it's also clear, placing wrong implants in any situation causes more stress because you're getting always closer to any anatomical structure. So it's very clear, like driving a car. When I drive to work every day 2 hours, the chance is higher to get an accident than when I have a 5-minute drive. This is obvious, and the same is here with short implants.
And might also create more stress on bone because you heat the bone more, you drill deeper. And
exactly. So this was our vision and our hypothesis to really reduce the invasiveness. We even went further. Now we do have the time to discuss, do we? Yeah, I need to hurry up. Because I love it. It's, we even were thinking today when you have a cell phone and it doesn't work anymore, you don't go to repair it. You're going to throw it away and buy a new one. The same is true for any radio or whatever electronic device. And maybe we were thinking, why doing this unhappy peri-implantitis treatment around these implants, just take it out and place a new one. Also, from that point of view, that was the theory. Now, listen carefully. Now we look at the 5 years old. Still 86 implants here, which we have. And now you start to see we have lost now significantly more on the short implant side. So we have now lost 4 versus 0 in the control side. And that contribute to 91% survival rate versus 100%. And now we start to become statistically significant. And now it starts to become like, because that doesn't feel well. After 9 years, when I tell you you have 90% survival, you say, excellent, Ronnie. Today in 24, I don't want to have a 91% of survival rate. So we could see something has happened between year 3 and year 5 with these short implants, which looked perfect before. And this really added kind of some stress in us. We said, why did we lose these implants after 5 years? I'm going to show you these 4 implants, which we have lost there. And you can see here, they have one thing in common. None of them had any bleeding or probing. None of them had any signs of peri-implantitis. Each of them, you can see, has like a more mineralized part around the implant, and they came out like sterile implants, and the surface of the implant looked perfect. You could just place it in again. So there seems to be that there was a stress on the level of the bone, which at the end came to the point that the implant was not anymore osseointegrated, and it came to a deosseointegration and not in a way of an infection. And we always had the debate about no, overload doesn't exist. And this was really hitting our attention. And also when you looked at the marginal bone level, they still look amazing. It's 0.2 versus 0.1 millimeter of bone level changes over 5 years. So from all parts, we had to see that we have healthy implants, we have a great bone level, but we see more implants now seeing that they get deosseointegration. And now, my dear friend, I also can provide you even with a 10-year result. We have followed these patients also over 10 years, and now we can unfortunately see, or whatever, that with the long implants, we're still in the level which we know. We are above 97%, so this is what we commonly know. And with the short implants, we even lost more, and we have now 85.7%. And this is below what we consider today as a modern implant. And this was really frustrating, and we had to conclude that short implant exhibited significantly lower survival rates compared to longer implants over 5 to 10 years, whereas there was no difference between upper and lower jaw regarding the survival rate. And the crown to implant ratio, the implant length, had no significant effect on any of the parameters we looked at. And again, it was a proof that the crown to implant ratio has no effect. So when we look at these, maybe our...
Ronnie, just one quick question. Did you see any like in the secondary outcomes, like any clenchers had more loss or anything which could give you a hint?
It was sufficiently powered with 86 patient and 86 implants, all single implants. It's a nicely powered study, but I think it's not enough. You know, this is the problem with, you still lose about only 5 implants, and how would you make any relation to that?
Got it.
But it was especially for it was for Christoph there as well, because we really shared this passion to say, okay, it would be so much more easy to just place short implants, and we don't need to have longer implants anymore. But we have to face the fact, no, that theory doesn't work. When I can place a longer implant, I should place a longer implant. And then this leads us now to the second part. What about when we really have limited bone height? What does make sense there? And there we have a super nice study done by Daniel Thoma from our clinic. And Daniel was leading a multi-center study with about 12 centers. It was a very comprehensive study, again, a very highly powered study, where they compared now implants which have been placed in areas which we have 5 to 7 millimeters, and they either got a graft sinus elevation procedure, placing it in an 11 millimeter implant or longer, or to go for a short implant without vertical augmentation. So here again, we do not compare implant length, we do compare 2 different protocols. Important to see now the difference. Now, again, this was 101 patients which have been involved. Again, a very nice study for all evidence side. It cannot be better, comparing the grafted sites versus the short group. And also here, when we placed more than one implant, we always restored them as single implants in order to have really the true effect of the short implants. And I will come to the final conclusion that I would not do this in today's situation. So also here, Stefan, you also did a great job with your implants. I would also splint them. But again, for the purpose of the study, we had single units in order to be comparable. Now, what have we found out? We have found out that with the long implants after 5 years, or 5.5 years was the mean, the observation period was 100% for the long implants receiving a sinus elevation procedure, and 98.5% for the short implants after 5 years. There was no difference also in marginal bone level. So here we have excellent marginal bone level stability in these areas. Now, in this study, it becomes important not just look at the implant parameters. We need to look also on these parameters which become more and more important. This is related to the patient outcomes, also to the dentist outcome. What is the surgeon doing? So when we look at the duration of the surgery, it is very obvious. We had about 50% more time needed for doing a lateral window approach compared to a short implant. So it is more time consuming doing it. It's also obvious we did the patient morbidity, that we had 100% more morbidity in terms of medication intake, painkillers intake than others. And I'm so sorry. And we had also to look at the cost in that area. And also here, not a surprise, it's 100% more costs. So double the costs for when I'm going to go for a vertical augmentation versus a short implant. Now, taking all these into account, we also want to know how these implants look after 10 years. You can see I'm thorough today, so I put together a presentation which we can have really long-term data. So here we can see we still confirm what we have seen, still 100% survival rate for the long implants, proving that what we are doing also with all these augmentation procedures are successful, versus 96% for short implants with no statistically significant difference, and also minimal marginal bone loss in these different groups. So taking these also big studies, multi-center study into consideration, we could conclude, number one, based on 5 and 10 years data, both treatment modalities are equally safe and predictable. However, short implants show similar results with regard to marginal bone level and implant survival as long-term implants with sinus elevation procedures. But short implants are associated with significantly less mobility, shorter treatment time, and lower costs. Now, with all this information, I provided Jennifer.
And Ronnie, going back to that 2 studies, sorry for interrupting, but do you have an explanation for that? I mean, why does it work in insufficient amount of bone, and why doesn't it seem to work in a massive amount of bone?
Mm-hmm. I think we don't have a clear explanation, but we do believe that here we exclusively looked on upper jaw implants, and we have lost more. It was not significantly different, but we have lost more in the lower mandible with the other study. And this might has an effect because of the more cancellous bone we have in the upper jaw, providing more flexibility and less stress on the bone. Because obviously, as you have seen before, there was more stress on the bone there, and therefore it came to this result.
So the same explanation which you had from the Belso study, more flexibility,
yes,
which was then in the bone and not in the superstructure.
Exactly.
Okay.
Again, this is just speculation. We have not proved that, but it's super interesting. I think it's super interesting.
Totally.
Now Jennifer is she has still the option of looking at one of these great looking guys, except me. To who should you?
Very, very hard decision.
Now, Stefan, turning the I know it's not my job, but turning now the card around. When you would be Jennifer, what would you choose?
Ronnie, this is so unfair. You're my boss. What should I say?
No. Listen, just go.
No,
You
I'm kidding.
state the way you want to be treated.
Absolutely, Ronnie. If I always think, if this is my sister, if this is my mother, what would I do? I would definitely go for short implants. Definitely.
So she was also again confronted with this situation, and again she has the privilege, and again no patient might not have, because she could really go to top clinicians worldwide. She could just pick. And taking all these into consideration, also her in her environment, again, she's still working at a very important implant company, and she wanted to also go back to work without looking like monster, and she wanted to go back in a reasonable way. So taking all these into consideration, knowing the risks we have encountered with the short implants, she decided to come to Zurich and come to me in order to do these implants. And that's what we did. I did this treatment together with Anina Zürcher, one of my faculties at that time, but she was a postgrad student. And we did shorten the presentation that we have more time to talk. So we did on both sides, as I said, a free changeable graft in order to increase the thickness at the width of the keratinized tissue. And I think in these areas, it is important to do a proper three-dimensional planning. I haven't shown all the steps because we don't have the time to. So that means you have a diagnostic part, you do a try-in, and really do this properly in a three-dimensional way. I think these are not the cases which you just do traditionally, and also I do a lot of cases traditionally without any three-dimensional analysis. Here, I think we need to use modern diagnostics to really evaluate the best possible implant position for each of these sites.
Ronnie, I still would stay with this for a second because I think it's important. I also have the feeling that short implants are definitely more difficult to place than classical implant, because you're always deep down in the vestibule, it's bleeding, it's always mucosa. So how important is it to not only do the diagnostic, but to have maybe a navigation standard template? How would you judge this?
Yes, no, man, it's clear. It's anyway, again, we now going back to the first study, the honest study comparing short versus long implants. Their short implant, basic short implant, is not more demanding than, in contrast, as you said, actually it's less stressful because you have less distance to drill there. So there it's not much of a stress. It's more like a mental thing that you think it's strange to have to place a short implant when you can place a 10mm implant. But yes, in these areas, it is stressful because we are dealing with a highly resolved case, and it's deep in the vestibulum. It's more difficult. But again, this is so true for any augmentation technique. It's even worse. So it's obviously more simple to drill 2 holes on both sides into the patient's jaw than to harvest autogenous bone. Sure. And build up that bone. And she was also asking, for what reason I build up the bone in order to have then an 8mm or maybe 10mm implant maximum? What is my additional quality of life comfort? And this was then her decision that she said, no, I'm going to go for the short implants, which you can actually go back to work next day, because that's not so invasive.
Got it.
That's what we did. And I have to say, we do this with a stent, but in this situation, I always have a physical check on the situation. So I want that would be never done in a flat position, never ever, sure. Because we do need to additionally check the positions of our implant sites. And this was then the final reconstruction, which she got in place, again, both connected. And this is now about 3 years ago, and she's still very happy. And every time I see her at the congresses, she loves me and I love her. So we are really finding the right way. Now, when we try to learn, and I want you, ladies and gentlemen, to learn from all the mistakes we did in the past. And when today I have a very clear understanding when to use what. So when we summarize these, we have to say today, short implants were, when we look at today's literature, were found to have a higher variability, and a lower predictability in survival rates compared to longer implants of the period of 1 to 5 or 5 to 10 years. That's a fact. That means when I do have the chance to place a longer implants, it doesn't make sense to place a shorter implant. Short implants, however, are a very valid option in situations where we have reduced bone height, when it is important to avoid possible morbidity associated with augmentation and reduce treatment time and treatment costs. And again, modern medicine, when you look at medicine, they also could still cut the entire chest open in order to fix something on the lung or on the stomach. No, they go in a laparoscopic way. And again, in medicine, it's very clear. You always need to choose the least invasive technique with the maximum efficiency in this setting. And this means in a situation where I am able to place short implants, I should place short implants to avoid the morbidity, stress, also on the operation side, and the treatment time and costs. Because there is no additional benefit to the patient having a longer implant there. What is also has been shown in the literature that splinting of short implant is recommended whenever possible. And maybe coming back to the first study, if we would have splinted them, we might not have lost that many implants there. But again, our job as a university is also to test out the limits and where is the limit of the biomechanical stress. And as you said, yes, bruxism must be identified and controlled to avoid further complication. And for me, whenever we have these issues, I just discuss it with the patient. And the patient, which is a bruxer, we try to treat it as a bruxer. We try to bring the patient on the same eye level. And dentists often want to make them too important. And they think they always need to take the whole decisions. No, bring the patient into your team. Bring the patient on the eye level and make the decision together. That reduces your stress significantly. I always sleep well because I never need to worry. I don't need to go to church to pray whether my case is going well. I don't need that. Just select the least invasive part and bring the patient on eye level. And to overall conclude, short implants represent an important instrument in today's implant therapy, reducing invasiveness, cost, and treatment time in cases with limited vertical bone height. There are still cases where we do need to do a bone augmentation, but I think this is what we consider today as the standard of care. And for me, maybe most important, and I conclude with this part, most important, and I think you said that very nicely, Stefan, whenever you make any treatment decision, try to treat your patient exactly the way you or your family want to be treated. When you do this, when you follow this principle, I can tell you the truth, you will never have any problem in your professional life. And the patient will feel this. So try to do it exactly the way you want to be treated. And it's interesting. I have a lot of dentists which are patients of mine, a lot. And they're the least invasive ones. They always want to try even to save a tooth, which everybody would say, get the tooth out. So again, try to treat them the way you want to be treated. And with this, I would like to say thank you to my amazing team. We have a world-class team. I'm proud every day, and I'm so happy to be part of that team.
Ronnie, that was just amazing. I love it. I love your presentation. I love how you do it. I love how you show the failures. And I also even love more that you publish your failures. I mean, chapeau, who does that? This is amazing. The only thing I'm thinking, maybe the patient of Istvan and Luca of tomorrow morning, they're going to reschedule their appointment for you. And you're going to have 3 surgeries tomorrow morning. So, but let's see.
I'm not scared of them. They are champs. They are still, when we have to face the fact, these are, regeneration is not just to place then short implants. It's also sometimes to be restored and the riches, obviously. But again, I think it was a very honest situation. And today I can really present this from the bottom of my heart because I truly believe this is the way how modern treatment and modern dentistry works. And again, Ronnie, it's not about us. It's not about what we like to do. And this is also maybe an age thing, Stefan. I think getting older, I don't need to prove myself. In the past, you wanted to do large augmentation. You were so proud that I can say, "Hey, today I transplanted that piece of bone and I did everything." No, today I'm actually happy coming home by being able to provide my patient with the least invasive way and make them happy and then make them cure as fast as possible.
Ronnie, that was amazing. People applaud you. Great presentation, beautiful moderation. Okay, but and there are some very nice questions. I want to hand them over to you. I think a very nice question comes from Eva Milinkovic. Hi, Eva. The question is, what do you think about crown to implant ratio? You say it doesn't make any difference coming from the literature. Is there a safe zone which you could tell us? There was always 3-to-1 ratio or whatever. Or let's put it clear, there's actually no safe zone or danger zone in their perspective.
Hi, Eva. When I make it very provocative, I don't care. I really don't care about. I never consider anything related to the counter-implant ratio, and I can sleep perfectly. It takes me not a second to fall asleep.
Great. Very short and very clear answer. There's a very, very nice question, which I thought it's very good and very, very thoughtful. Ali asked us a question. What is your opinion regarding using short implants in maybe a full arch case as a splint, as a tilted implant? I think a very interesting, good question. Ali, good question.
I love that. I love that. And also here I can provide you not yet with an answer, but we have started, unfortunately, this was in COVID, a study which we do together with the university in Pune in India, which we have two very good friends and collaborators, which one of them worked for 1 year with me. And we do their full arch reconstruction, which are randomly divided into either going 2 straight ones and 2 tilted ones versus just short ones. But the study is ongoing and it addresses exactly this, whether there's any benefit going for longer tilted ones, or whether there's a benefit going for shorter implants, which are straight, or whether it doesn't matter what you're going to do. But I think it's a super hot topic and I'm super curious about the results of that study.
Great. There's also a great question, which I also like, and which I have a little bit also a clinical problem sometimes with it, from Per Oscar. Do you prefer transmucosal tissue level implants when you place short implants? Obviously you do. And do you have any problems or do you sleep bad? Let's come back to that, because you might always have a transmucosal loading during the healing process. Is that any concern you have?
Yeah, that's definitely a good question, and I was interested in what Stefan makes nervous when you say in your clinic. Yes,
that makes me nervous.
That is a topic that is related to about what kind of temporary reconstruction you have there, about how long this edentulous area is, and this could be an indication in certain areas going for a more bone level type of implant. But yes, in general, I do prefer kind of an implant with a transchangeable part, bringing also my implant shoulder away from my bone level, especially with these short implants. I do prefer these whenever possible. But if I really have concerns regarding implant stability and the load coming from the temporary prosthesis, then we also can go for a bone level implant.
Ronnie, we have so many questions. We're already at the end of our presentation, but I think everyone don't be sad when I don't answer any question. But we will see Ronnie in Milano and just come up to us. I think there's also a very nice question which I like. We sometimes hear that you double the amount of let's call it implant surface when you increase the size and the diameter of the implant. Sometimes you hear per millimeter, you increase it and whatever. What do you think about that? Is it useful to place a more wider implant? Because sometimes you really have the clinical scenario that you don't have enough height, but a lot of times the bone is thick.
Yes, I love that topic. It's one of my favorite topics. And again, I couldn't care less. For me, this is a discussion which we had literally 25 years ago, when it was about the two big implant companies, one with a machine surface, one with a structure surface. And there we presented cases measuring the surface on each of the implant. And today in 2024, I couldn't care less about that. So every short implant with a structured surface has more than sufficient surface in order to be integrated. And I actually never use a wide diameter implant because the wide diameter implant creates so much more stress in the anatomic situation. You really need to have a very wide ridge. And we also do know that overall wide diameter implant have a lower survival rate. And most likely, it's not clear. It's due to the fact that you reach with the implant diameter more the cortical bone of your jaw, meaning I mean an area which is less. We have less vascularization. We have less biologic activity. So therefore, I always say when I would have an implant company, my own implant company, there would be no implant larger than 4.5 millimeter. No one. But I would have a
And I
lot
will
of
be your first
short.
customer, I swear. The
But I know
young one.
the Americans don't share that part, but I assume that there's not a lot of Americans, so I don't disappoint them. I love them. My wife is American, so that's why I can say this. But for me, that doesn't exist.
Okay, great. Ronnie, we are already overdue, but I just want to ask you one more question from Friedrich Mausner, a friend of mine. He also asked towards implant crown ratio or abutment crown ratio. I think we answered that, but he asked a very interesting question, which is also part of the literature. We see in the literature that if you place 3 implants and you splint them, the middle one has a little worse prognosis. Do you also see this? And does this make any clinical conclusion for you?
That's a super question.
Mm.
I was not aware of them, and that would be the only critique which I would have to your lovely case you showed at the very beginning. I would have not placed 3 implants. I would have actually placed 2 implants. I would have left the one in between. And I do have the confidence again into these short implants in a splinted way that I would not use for every tooth than a short implant. But again, this is just now we talk about clinical experience, and this is how I would do the case.
But that was a little a goal I put in my own in my own goal because I actually put the finger on that. Yes, that is a little bit due to the factor I am a little bit afraid of surface, but you took that sorrow from me now.
Whenever you worry, just call me at any time of the night and we talk about it, and I will take away all your worries.
But you told me you sleep so well, so how should I wake you up, Ronnie? There's one last question, and sorry for everyone who I couldn't answer. And the last question is always mine, and maybe a short answer. I would, as a periodontist and a surgeon, I would love to ask you about your occlusion concept on implants, maybe also on short implants. Just very quickly. Do you put them in infraocclusion? Do you have any dynamic contacts on them? Just 2-3 sentences, Ronnie.
That's another one of my most favorite topics. I really spend very little time on occlusion. Speaking as a prosthodontist, but I do look that I look for a balanced occlusion on both sides. So I don't want to have just obviously contact on the implant, but I don't use the implant in a way that I really try to get it out of the contact. So I still look at a balanced situation. I always look at in the function that there is no stress on the implant crown or crowns or whatever. But again, at the end of the day, the problem of occlusion is only then when a patient is par functioning. And our job is to also, before we go into, this is part of the risk assessment, before we go into an implant therapy or any kind of reconstructive therapy. I'm making a lot of just full mouth reconstruction, implant and teeth. So that's my job at the very beginning, to kind of assess the patient's habits, the patient's parafunction, and to train the patient in a way that the teeth are in touch per day in average about 15 to 20 minutes. And this is only during eating. And outside this time period, the teeth do not touch each other. So our job is to really make sure that the patient is not parafunctioning. And then we also, the occlusion is not an issue of that. And if a patient cannot be really adjusted to that, which usually always works, it's a different treatment aspects, how you can do this. It takes months before the treatment, but I think it's an important part. And if they still have some concerns, the patient just receives a splint at the end of the treatment. So this is how we deal with occlusion and parafunction.
Ronnie, that was amazing. That was also understandable for a periodontist, which means a lot. And I'm so happy now I can call you at any time of the night.
Yes,
I have so many questions, so please put your cell phone on the side because I will ring through tonight. That's for sure. Ronnie, it was amazing. It was so great to have you. Everyone loves you here in the comments. They applaud you. Amazing presentation, great and clear. Everybody loves you. We didn't address all the questions. I just want to tell everyone, please come to Milano to our annual congress. It's from 25th to 26th or 24th to 26th of October. There's still seats available. It's going to be a great, amazing program. And with this, Ronnie, I wanted to say thank you on behalf of your organization. It was great to have you as a president. It was a pleasure for me. And Ronnie, please, the last words are for you. Thank you and goodbye to everyone all around. Ciao, ciao. Please, Ronnie.
So again, for me also, it was for me an exceptional evening, I have to say. I haven't seen the other people. I always love to be in touch with them. But Stefan, a huge compliment. You're a superstar. I admire you, and I'm so happy that you're going to do that job for the moderation. And it's so much fun. And this is the most important part. You should love what you're doing, and you should enjoy your friends. And this, what we did this evening, thank you to everyone. And I'm really confident you guys are all going to show up in Milano. By today, we have 4,266 participants. And I think this is absolute world record for an annual meeting. So we are really looking forward to a huge party in Milano. See you there. And thank you again for your trust and your friendship.
Thank you. Ciao, ciao.